Out of the medical option given, amiodarone and the flecainide have a significant body of evidence in prophylaxis against atrial fibrillation in the WPW. Sotalol is another agent that prolongs the myocardial refractiveness and may be used in some patients. My question is, flecainide is given here as a prophylactic. If it is contraindicated, how can we give? What is the most appropriate management of this patient? A 38-year-old female presents with a history of progressive shortness of breath of 3 months duration. She gets short of breath on the
voice, doctor. Before was clear. Now, voice.
Yeah, your voice is clear. The enteroseptal hypokinesia with an ejection fraction of 38%. 12 lead ECG confirms monomorphic ventricular tachycardia. He is electrically cardioverted and returns to the sinus rhythm and Q waves in the leads V1 to V4. Which of the following is the long-term treatment indicated?
Option D.
Long-term prevention is yes, ICD.
1 month ago.
Studies have shown that implantable cardioverter defibrillator are superior to the antiarrhythmic in patients with the history of life-threatening VT, and studies suggest that they are associated with a reduction in the absolute mortality of 7.9%. 68-year-old lady has had more than 3 readings of blood pressure of 175/65 during the past month. She is obese with the body mass index of 34. On further questioning, she admits to shortness of breath and minimal exercise, and occasionally she awakes in the night very short of breath and has to open the windows. Okay, PND is there. She does not report suffering from any excessive sleepiness in the daytime and is able to maintain her job as a busy PA. Which of the following is the most appropriate initial therapy in this patient? Short PND, orthopnea. Okay. Pressure, high blood pressure. Ramipril?
ACE inhibitor, I guess.
Yeah, ACE inhibitor.
Her blood pressure and also.
Pardon? Yeah, we
go, please, go.
Ramipril or thiazide?
No, I don't think thiazide. It should be
like this LVH sign of LVH.
Yeah, LVH sign. We have to decrease the pressure, and that will monitor. While NICE guideline recommend calcium channel blockers in the over the 55 age group, her obesity and the heart failure would drive you towards the ramipril. Her shortness of breath may be indicative of the left ventricular dysfunction. Therefore, ramipril would be the best choice. Meta-analysis have suggested that ARB or ACE inhibitors are associated with the lowest incidence of diabetes. NICE guidelines recommend clinic blood pressure and the subsequent ambulatory blood pressure monitoring for the diagnosis of hypertension. Screening for complication, that is target organ damage, is required, including the ECG to exclude the left ventricular hypertrophy or the previous cardiovascular events. Urine dip for protein, renal function test, and the hypertension retinal changes. And in addition of the lifestyle modification, medication can be initiated, in this case grade 2 hypertension. What what is the most likely diagnosis? A 19-year-old football player has been referred to A&E following a pre-season medical. He had spent the morning training and was subsequently undergoing a series of testing, including the NECG. When the ECG was taken, it showed the ST segment elevation in the anterior chest lid, and he was quickly referred to the emergency department. And on arrival at the emergency department, he was comfortable but anxious at first. He had no chest pain during or after the exercise, no shortness of breath, and no dizziness, loss of consciousness. And his past medical history was unremarkable, and he was not on any medication. His physical examination was entirely normal, chest X-ray normal, ECG sinus rhythm with 2 mm concave ST elevation in the V2 to V5, and J point notching to is seen with the peak T wave. Answer. Likely diagnosis.
This
J
this
point
pericarditis. Pericarditis.
diagnosis here. No, pericarditis. No.
Early
WPW.
repolarization looks like.
In WPW, there will be the
Delta
that is delta wave, and that will
J point.
This
This
early repolarization.
No symptom. Pericarditis patient has. This is
This B.
J point notching is what with the peak T wave.
Pulmonary embolism. Pulmonary embolism.
Because this early repolarization. No symptoms now, so?
Yeah, I will go for that B. Because pulmonary embolism, there must be some symptoms.
Yeah, no symptoms. This early
And in the
repolarization.
pulmonary embolism, S1QT, QT will be the features, not the concave ST elevation.
Yes.
And he is a player also. There exists a benign but often alarming electrocardiography entity that present with the ST segment elevation. It is known as the early repolarization variant and expresses as an early uptake of the ST segment before the descending limb of the R wave has reached the baseline. Features of the early repolarization variants are classically the ST segment elevation during the early exercise return to the normal as heart rate increase further. It is common in the black males. Clinical evaluation is entirely normal. ST elevations is usually seen in the precordial leads. "45-year-old lorry driver present to the emergency department with the central crushing chest pain. His initial electrocardiogram shows the ST segment elevation in the V2 to V5. The patient is undergoes PCI and intervention with one stent to his left anterior descending coronary artery. And following an uneventful 5-day period on discharge home and aspirin 75, ticagrelor 90, bisoprolol of 5 and ramipril of 2.5, atorva of 80. He would like to know when he can go back to work. There is no residual chest pain. Which of the following statement is correct? Option A, he has to stop driving, inform the driver DVLA, and return for the exercise tolerance test in the 6 weeks on the current regimen. No, and he has to stop driving, inform the DVLA, and exercise tolerance test in the 6 weeks after the stop has stopped his bisoprolol for 48 hours. And he has to stop driving, inform the DVLA, and return to the exercise tolerance test in the 6 weeks after he has stopped all the medication for 48 hours. He has to stop the driving, inform the DVLA, and return for the modified exercise tolerance test in the 6 weeks after he has stopped all his medication for 48 hours. He can return to driving in 1 month provided an ECG shows the preserved LVF.
I think E.
I will go for B.
C and D are same, sir?
E.
No. In the
DVLA and again for modified. What is different then between modified exercise and exercise carrying? Shut up.
No idea. vocational group 2 drivers, the DVLA guideline state that the patient has to complete stage 3 or of the Bruce protocol exercise tolerance test. There should be no residual chest pain or significant ACG changes. The only anti-anginal medication this patient is on is bisoprolol, and his symptoms are stable. If it is stopped before the test, this increases the chances of achieving the target heart rate of Bruce stage 3. Before speaking to the patient, the DVLA guidelines on the subject can be found on the DVLA website. Okay. We have to stop that bisoprolol and then go for the test. 35-year-old man is being treated for the end stage cardiomyopathy following viral infection. His current medication include the aspirin, bisoprolol, ramipril, and furosemide. There is still evidence of cardiac failure. Echocardiography 3 months earlier revealed the ejection fraction of 31%. Which of the following medication best evidence to respect to survival benefit?
Spironolactone. Yeah.
Yes.
Yeah, digoxin has no role in the survival, and the other are no role here. Among this is the same. Pardon? We have to calculate NIHA also. For patient with the chronic heart failure with the NIHA 2 to 4, already taking a beta blocker, angiotensin converting enzyme inhibitors, and loop diuretics, an aldosterone antagonist such as spironolactone is recommended. The RALS studies demonstrate benefit of the adding spironolactone in these patients with the severe heart failure and ejection fraction of below the 35%. The study showed a relative risk of 0.7% for all the cause mortality in the group taking the spironolactone. The study used low dose spironolactone at a dose of 25 milligram per day. The paradigm HF study demonstrated the benefit of dual inhibition of the renin angiotensin aldosterone system and neprilysin inhibition compared with ACE inhibitors alone. The dual inhibitor, better known as Entresto, valsartan, sacubitril, okay, represent a major development in the heart failure treatment. The new combination can be used instead of ACE inhibitor or the angiotensin receptor blocker for the treatment of patients with the heart failure with reduced ejection fraction. Sacubitril, valsartan, Entresto. Which of the following medication is used with a particular caution in this case? 76-year-old women with known rheumatoid arthritis present with the 3-month history of breathlessness. There is no past medical history of ischemic heart disease or the hypertension, and she denies any history of chest pain. She had been on celecoxib for the heart arthritis up until a year ago when she was dosed to the ibuprofen. She has also been on methotrexate for the last 15 years. On examination, she is found to have a blood pressure of 100 by 70 and the heart rate of 125 and irregular. Her JVP is raised at a 5 centimeter H2O, and there is a bipedal edema to the mid calf. Her heart sounds are normal, and her chest is clear on auscultation. On an electrocardiogram shows the atrial fibrillation with the normal complexes. A chest X-ray revealed a small an echocardiogram shows the left ventricular hypertrophy with the speckled myocardium. There is a biatrial enlargement with the no significant valvular pathology. Which of the following medication is used with particular caution in this case? Dioxin. Yeah, yeah. This patient has a feature consistent with the restrictive cardiomyopathy, the history of the rheumatoid arthritis, and the echocardiographic finding of the bibasal dilatation. ventricular hypertrophy and the speckled appearance of the to the myocardium make amyloidosis the most likely underlying cause. The digoxin is used with caution in the amyloid patients as digoxin binds irreversibly to the amyloid fibrils. Which of the following is the most appropriate option in this case? 42-year-old man with a history of asthma present to the ED with the palpitation and the lightheadedness. He has had two previous episodes of asthma which require admission to the intensive therapy unit, and he is currently managed on the salmeterol fluticasone combination therapy 500 milligram by 50 and salbutamol PRN. On examination, he has a pulse of 160 and the BP of 89 by 60. There is a bibasal crackles and auscultation of the chest. You try to Valsalva maneuver, which fails. Sorry. And the investigation, hemoglobin, okay, everything looks normal here. Which of the following is the most appropriate option in this case? Verapamil.
C.
Patient is unstable. Okay.
Yeah.
But why they try Valsalva maneuver? Just go for DC cardio. They're trying to confuse us. Okay. This patient has an episode of paroxysmal SVT and is relatively decompensated with the systolic of 89 and bilateral basal crackles. As such, electrical cardioversion is the most appropriate management option. 76-year-old man with a history of chronic asthma managed with the high dose seretide comes to the A&E complaining of palpitation. He has felt very faint with the shortness of breath for the past 30 minutes. Two further episodes occur during his time in the emergency department, documented as fast atrial fibrillation. By the time you examine, his BP is 135 by 80 with the pulse of 80 and regular. ECG at the time reveals the sinus rhythm with the evidence of lateral ST depression. Which of the following is the most appropriate treatment for him to control his ventricular rate?
Why not amidron?
Rate control.
For rate control. Rate control. Yes.
For rate control, why not bisoprolol?
Because he's asthmatic.
Okay, I didn't see that. I'm tired actually. Sorry.
Yeah.
Verapamil is a non-dihydropyridine calcium antagonist, which is an appropriate choice to obtain long-term ventricular rate control.
Actually, reading energy consumer and also mind consumer.
Yeah. 45-year-old smoker present to the accident and emergency department following a prolonged episode of chest discomfort lasting 3 hours. His initial electrocardiogram ECG showed a segment ST elevation in the chest wall leads. Thrombolysis therapy with the tissue plasminogen activator is given on the advice of the cardiology team. The patient is admitted onto a coronary care bed and is discharged after an uneventful 5-day period. He represent after 1 month complaining of palpitation and dizziness. The electrocardiogram shows a broad complex tachycardia. Okay, and vitals investigation looks normal here. Sodium 3.7, potassium 3.7, urea okay, and corrected calcium is 2.21. Okay, magnesium is 0.88, also normal. A central line is inserted at the and the patient is loaded with amiodarone. His ECG reverts to sinus rhythm with the anterior Q wave. An electrocardiogram show enteroseptal hypokinesia with moderate left LV impairment. Which of the following is the definitive intervention?
I see the insertion.
Yeah. Automated implantable cardiac defibrillator is correct. The development of the ventricular tachycardia, ventricular fibrillation on the first day followed an acute myocardial infarction is thought to be no prognostic significance if dealt with the promptly. However, the late development of the VTVF in the context of the full thickness myocardial scar, as evidenced by the Q wave on the ECG, carries a very poor prognosis given that there is no evidence of any reversible cause electrolyte abnormality or to the BF and VT. It is very likely to be a scar tissue related to ventricular arrhythmia, especially with the presence of Q wave on the ECG, indicating a full thickness infarct. Pharmacological therapy with amiodarone to the terminate to prevent the recurrence in the acute setting is effective, but in terms of secondary prevention and long-term outcomes, ICD is superior to amiodarone. Merit to trial. Therefore, ICD is indicated in this patient. Good explanation. What is the most likely diagnosis? 67-year-old lady was admitted to the emergency department with central chest pain that had started 3 hours earlier. The pain was crushing in nature, radiating to both arms and associated with nausea and vomiting. She has a past medical history of angina, hypertension, and type 2 diabetes. She is on the following medication: Bristol trinitrate spray and amlodipine 10 milligram OD, atorvastatin of 40 milligram nocte, and metformin 500 milligram TDS, and aspirin of 75 milligram OD. On examination, she was sweaty with a blood pressure of 155 by 95, pulse 98, respiratory rate 24, okay, chest clear, a JB. Okay, 1 minute. JBP was just visual. First and second heart sounds were hard with no added murmur. The electrocardiogram shows the ST elevation of 3 millimeter in V1 to V4 with reciprocal ST depression in the inferior leads. Okay. Investigation looks normal. WBC is raised and okay, and okay, everything is okay. A bolus infusion of 1080 place was given together with the diamorphine and metoclopramide. On the next 30 minutes, she suddenly started becoming progressively hypotensive with the blood pressure of 72 by 53, pulse of 124, and auscultation of her chest revealed a pansystolic murmur, loudest at the lower left sternal edge, so associated with the audible third heart sound, DST. What
It's
is the most likely
VSD.
diagnostic? Yeah.
Yes.
Rupture ventricular septum.
Rupture ventricular septum.
The most likely diagnosis is rupture ventricular septum. This rare complication, according to the autopsy studies, occurring in 1 to 3% of the cases of MI, as opposed to around 10% incidence for ventricular free wall rupture. Okay, ventricular free wall rupture is more common than VST. Occurs most commonly after the anterior myocardial infarction. The clinical presentation ranges from the asymptomatic murmur to cardiogenic shock, post-infarction ventricular septal defect. Complicate approximately 1 to 3% of the cases of acute MI and account for about 5% of the early death after the MI. The average time from infarction to rupture has been reported to be between 2 and 4 days, but it may be as short as a few hours or as long as 2 weeks. Sorry. An echocardiogram should confirm and diagnosis, and Swan-Ganz catheterization would help determining the degree of biventricular failure. Mortality is very high in the order to 80%, and the outlook in this patient is very poor. And given her age, female sex, and the medical history of diabetes and hypertension, although that right-sided failure is more common in the patient with the post-infarction ventricular septal rupture, left-sided failure, and the refractory pulmonary edema are more prominent in the patients with Ruptured papillary muscle. Papillary muscle rupture is rarer with the reported incidence of less than 1%. Which of the following lifestyle modification will produce the most reduction in BP? 38-year-old male has been found to have the elevated BP on the several occasions over the last 3 months. His systolic BP has been around 155 and diastolic is 95. He has a 5-pack year history of smoking and consume 3 to 4 units of alcohol per day. He has no personal or the family history of coronary artery disease, a stroke or the diabetes. His weight is 93 kg and a height of 162 centimeter, and the rest of the physical examination is unremarkable. His ECG and the chest X-ray are normal, and the cholesterol of 5.2, HDL of 1, triglyceride 2.9 is high, and the sodium of 140, potassium of 4.1. Bicarb, chloride, and creatinine normal. You have decided advised him to about the lifestyle modification. Or which of the following lifestyle modification? Weight reduction to 83, diet rich in fruits and vegetable and low in fat, moderation of alcohol consumption, reduced dietary sodium in less than 6 grams, regular exercise without significant weight reduction. Wow. What?
I guess option D, reduce dietary sodium to less than 6 grams per day.
Yeah. But it is not confirmed. It is have elevated on the many occasions. What about the triglyceride is high, 2.9. Okay. So we go for that diet rich in fruits and vegetables and low in fat. Pardon? What is his present weight?
Why he defined 83? I guess reduces sodium.
Wait.
Yeah, I think it is probably talk about blood pressure. So how about salt reduction?
Yeah, for me also.
This patient has mild hypertension, systolic BP of 140 to 159 and diastolic of 90 to 99, and has no evidence of target organ damage. The British Hypertension Society does not recommend starting antihypertensive therapy in such patients, but lifestyle modification should be encouraged. Of all the lifestyle modification described, weight reduction produces the greatest reduction in BP. 10 kg weight loss is expected to decrease by BP by 15 to 20 mmHg. The effect of other lifestyle modification on the hypertension, as mentioned in the other option, is less than this. Option B, this only reduces the blood pressure by 8 to 14. Okay. Alcohol consumption, if reduced, then it will reduce the bus just 2.5 to 4. Wow. Option D, this reduces just 2 to 8 mmHg. A 67-year-old man present with exertional breathlessness and intermittent palpitation. On examination, his pulse is found to be irregularly irregular. At a rate of 120, the apex is displaced to the anterior axillary line. Auscultation of his heart reveals a systolic click associated with late systolic murmur. There are a mild bibasal crackles on the auscultation of his chest. His electrocardiogram confirms atrial fibrillation with the left ventricular hypertrophy. An echocardiogram confirms the presence of mild mitral valve prolapse with severe regurgitation and the left ventricular impairment with the ejection fraction of 50%. Which of the following is the management of choice for reducing his chances of long-term complication? Digoxin. digoxin plus aspirin, digoxin plus formal anticoagulation. Okay. Yes. This patient has evidence of cardiac decompensation, breathlessness with bibasal crackles and the displaced apex beat in the setting of MBP. With associated severe mitral regurgitation, patients under age 75 with mitral valve prolapse and who are in the atrial fibrillation or those who have echocardiographic evidence of left ventricular impairment should be referred for surgical assessment as early as possible. A toe can demonstrate the whether the valve is amenable to repair or needs replacement. This is often performed intraoperatively. Progressive mitral regurgitation is the most serious complication occurring in the about 15% of the patients over 15-year period. Acute hemiplegia, transient ischemic attack, cerebral infarcts, hemorrhagic fugax, and retinal arteriolar occlusion all occur more frequently in MBP patients, suggesting that cerebral emboli are actually quite common in this condition. Sorry. 78-year-old man has just driven his wife to the hospital for a blood test when he suddenly collapses to the ground. There was no chest pain. On questioning, he gives a history of previous collapses in the last 5 years with no predisposing factors. He gives a history of diet control, type 2 diabetes, and takes no regular medication. An ECG performed in the accident and emergency shows RBBB with the left posterior fascicular block. PR interval to 205 milliseconds. Echo arranged privately by the GP has revealed ejection fraction of 40%. You are asked to see him. What is the most appropriate management? Pacemaker. This is
BBC.
bifascicular.
Yes.
What is the option
B.
here?
Option B.
B.
Yes, B.
Given that his ECG is suggestive of possible episodes of complete heart block because of the RBBB and the left posterior fascicular block and the prolonged PR interval, it is likely that episodes of collapse represent a period of the complete heart block. He could therefore be listed for the PP and told not to drive until the procedure is done. Given the coexistent heart failure, here are the cardiac desynchronization therapy defibrillator would be the reasonable choice here. Okay. Patient came for his wife. 57-year-old man present to the GP with the tiredness. He had a prosthetic aortic valve replacement 6 months ago. The procedure itself was uneventful, but he now feels increasingly tired and lethargic. He takes warfarin and a recent INR of 3. On examination, he looks pale, of PP of 105 by 70. On auscultation, the prosthetic valve is easily audible, and there are bilateral coarse crackles on the both lung bases, consistent with mild LVF. Hemoglobin of 9.7, MCV of 105, reticulocytosis decreased, haptoglobins, and WBC of 5 platelet. Okay. Sodium, potassium normal, creatinine okay, ESR is normal, albumin 39, ALT okay, bilirubin very high. Which of the following is most likely diagnosis? Valve hemolysis.
Yes, option C.
Valve hemolysis is associated with the prosthetic valve replacement. It occurs because of mechanical destruction of the red cells and leads to anemia with increased reticulocyte count and decreased haptoglobins. The bilirubin elevation is likely to be due to the rising unconjugated bilirubin because of hemolysis. What is the most likely complication? Okay. 70-year-old man was admitted to the radiation laboratory when they received urgent coronary angioplasty. Subsequently, he was transferred to the ICU for further care. 2 days into his recovery, he suddenly developed recurrent chest pain, and his blood pressure became unrecordable and went to the profound shock with the electromechanical dissociation. Resuscitative measures were started, but the patient died within few minutes. Yeah. And what about the septum? Yeah, shock is there. Patient is in shock. Or what about the mitral regurgitation? Yeah, sometimes murmur will not be audible. We did in the one question in the free one. And that murmur is not necessary always we get the murmur. Okay, in the morning we did one question and explanation. They said yeah, yeah, yeah. Autopsy studies reveal that the ventricular free wall rupture occurs about 10 times more frequently than the post-infarction ventricular septal rupture. In about 11% of the patients following the acute myocardial infarction, ventricular rupture and the cardiogenic shock are now the leading cause of death following the acute myocardial infarction, and together account for over two-thirds of the early death in the patient suffering from their acute infarction. Ventricular septum, post-infarction ventricular septum rupture is less common, and ventricular free wall rupture is more common. 50-year-old man comes to the cardiology clinic for follow-up. He has been annually followed up in the clinic for 10 years for his aortic stenosis. He informs you that his exercise tolerance has decreased. He has experienced some chest discomfort and dizziness and strenuous exertion. On examination, he is comfortable with the blood pressure of 125 by 85 of pulse of 76. His JBP is not raised and his chest is clinically clear. First and second heart sounds are heard, and there is an ejection systolic murmur of 3 by 6 in the aortic distribution. And on echocardiogram, gradient of 60 is found across the aortic valve. Okay, and you explain to the patient that he will need a valve replacement. You would like to know the pros and cons of the different heart valves. Which of the following statement is true for prosthetic heart valves? A tissue valve would be the most suitable for this patient. What is the age of this patient? 50 years. Okay. Both tissue and metallic valves need anticoagulation for life. Tissue valve lasts as long as metallic valves. A metallic valve would be most stable for this patient, and tissue valve most last for 5 years on average. Yeah, young patient metallic valve, old patient, yeah, valve. Yeah, we don't give that warfarin in the pregnant lady, so that's why. A metallic valve would be most suitable for this patient because he is young. The negative side of metallic valve is that he will need anticoagulation for life, and data from the review published in 2012 also support the view that the hemodynamic performance of the mechanical valve and the anticoagulation may drive better outcomes versus tissue valves. 70-year-old woman comes to your clinic to follow up. She is a known patient with the stable heart failure, NIHA 2, due to the ischemic cardiomyopathy. She has a chronic atrial fibrillation and has been anticoagulated with warfarin. Her last echocardiogram shows biatrial dilatation. Other medication include the digoxin of 125 microgram OD, furosemide of 45, and ramipril of 2.5, bisoprolol 2.5, and her resting pulse of 61, and blood pressure of 132 by 82. Today her INR is 2.7. So she would like to know whether there would be any benefit if she has cardioverted to the normal sinus rhythm. How would you advise this women? Breath control is better than rhythm control with respect to stroke, and she should be referred for electrical cardioversion. She should be switched to amiodarone in attempt to the cardioverter, and rhythm control is has no survival benefit and rate control over the rate control strategy, and she would benefit from evaporating. No evaporating. In a stroke, which one is better, rate or rhythm? No. I'm asking about option A. Why is this wrong? Wrong. Yeah, we have to control that. Yeah. Yeah, the patient is having some underlying disease and heart failure. We have to go for that rate control. Current evidence suggests that rhythm control has no benefit over the rate control strategy, and indeed, there was a trend to decrease mortality and decrease cardiovascular events in patients treated with the rate control intervention. Option A: any difference between the rate control and the rhythm control on outcome did not reach the statistical significance. Okay, as he should be referred for electrical cardioversion. In this situation, with the dilated cardiomyopathy, electrical cardioversion is unlikely to be successful and would not be impact on outcomes. Okay. 56-year-old Indian male present with the history of shortness of breath on exertion 3-month duration. For the last month, he has been unable to walk on one block without getting short of breath. He has also noticed swelling of his feet. On physical examination, he has a JBP a low volume pulse of 95 and pulse BP of 95 by 60, harsh ejection systolic murmur at the aortic area, and a left-sided heart sound, third heart sound is 3 gallop and inspiratory crackle on the both lung base. He has been diabetic and hyperlipidemic for the past 6 years. His medication include aspirin, fosinopril, and metformin 3 times per day. Okay, and echo is ordered, which reveals the severe left ventricular dysfunction with the ejection fraction of 28%, calcific aortic valve with the calculated area of zero point 0.6 with the transaortic gradient of 30. Okay, and what is the best step in this management? One minute. Gradient. No. Patient is having left ventricular dysfunction with the ejection fraction. This patient has a severe left ventricular dysfunction, and calculated valve area in such patients can be falsely low because low cardiac output reduces the valve opening force. It is important to distinguish patients with true severe aortic stenosis with the secondary a secondary LV dysfunction from those who have falsely low calculated aortic valve area because of low cardiac output. An important method of distinguish between the two conditions is to assess the hemodynamics after increasing the cardiac output of by dobutamine infusion during echocardiography or the cardiac catheterization. Patient with truly severe AS manifest an increase in the transaortic pressure gradient, while the valve surface area remains the same during the dobutamine infusion. While those with falsely low calculated valve area manifest an increase in the calculated valve surface area. Dobutamine echocardiography is also important to assess the LV contractile reserve. Patients who have the 20% or the more